I want to put some context to a core value that I have in evaluation of when somebody comes to see me, because I'm just a problem solver. That's all I do. You want to look at my degree? Go ahead. Yes. Physiotherapy gets somebody in the door. But if someone has what they think is musculoskeletal pain, we know that it may not be musculoskeletal. We know it can be tons of different constructs and even more different ways to help them succeed. But what happens when it's not something that's, it might be in my wheelhouse or any other individual's wheelhouse, but it's not in the mental construct of what the person's thinking? Meaning, the core value is I'm going to try to get you as far away from me as possible if I believe that the solution is the lowest hanging fruit somewhere else. Really what I'm going to describe here is, here's somebody that talks about intermittent chronic symptoms, back pain, hip, etc., etc. Now, we always look at what do they say, what do they do, and the truth. So if nothing really sticks, be like, yeah, the MRI has got something, but it's not a big deal. This isn't your problem, even though there might be a warranty to perform a surgical procedure. This is not who gets surgery. Remember, your MRI looks the same when you're in this positive intermittent state of your back versus when it's hot, okay? Now we look at, yeah, there's things that we're finding at a fundamental level, but I think when people have musculoskeletal pain, it's challenging to identify fitness as the primary, solution, because it's not who they came for. It's not what they thought their problem was gonna be. Let me take a step back. It might have been the last time I was in China. I don't remember because I haven't been in China in a while, but badminton is a big time sport there. And what we're seeing we're going to see similar things here with paddleball, where these two young men who were very high level, I think they were provincial level, that would be like a state level, and they had raging patellar tendinopathy, and blah, 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 blah. Clearly there was physical therapy intervention, but I said, like, the biggest issue here is fitness. Like, it's their volume, it's their load management. If they played less, or overloaded less, and of course the patellar tendon, based on coming to the net and having that quick deceleration, if they're not fit or strong enough, they're going to load the tendon a little bit more than what's ideal. And I don't remember if they had ankle mobility or not. That's kind of like a basketball player, why they have this significant patellar tendon issues. When you're jumping, it's a lousy looking squat, and the force isn't being distributed because you have to go straight up. You can't sit back. So there was a case of where it made sense because they weren't intermittent. They were hot, so there was a physical therapy type of mindset that would have fit of how they were looking for a solution. But I'm like, however long it takes, first of all, you got to sit out. Like, you can certainly develop certain qualities to be an elite badminton player, but if your knee hurts all the time during 9 hours of training, then you have to draw back. Like, this is a load management solution. And then we have to change, perhaps if we're going to go back to 9 hours, you need to be way more fit. Then we can look at the physical therapy pieces and maybe add in some ankle motion. Maybe they need to be stronger. But again, badminton, similar to tennis, you're going to burn lots of calories. So I'm like, the best solution is the coach, like the technical coach, because it has to be right. If I'm able to give somebody else the football, and leave money on the table, which no one ever does. People come to you, you're going to try to do what you do, but you're not even evaluating for other places that might be simple. Okay, so now let's go back to this individual. We'll call it back pain, intermittent back pain. We put together, some breathing. We put together some dead bug and some DNS stuff, and we put blah blah blah. What about some of these other performance measures that we can get from blood work or respiratory testing? And that is crucial. And I'm going to explain why in terms of what is feeding this intermittent threatening situation that doesn't appear to be pathoanatomical. That's a whole nother talk. But again, what is driving that sensory input? They give you 2 tests. Getting blood work now for performance is not hard. Like you just go on the internet and do it. You go to a LabCorp or wherever, you have somebody come to the house. There's a ghost physician that writes it up, and that's fine. Okay. The number that I think a lot of people are familiar with as it relates to diabetes is A1C, and A1C is somewhat of an aggregation of your blood glucose over the last 3 months. It might be a little bit more complicated. Hemoglobin is a little bit involved in that, hemoglobin A1C. But think of your A1C is higher is not so good. I think if it's in the sixes, you're going to probably, whether somebody has a very complete background of these things or not, you're going to say you're at least pre-diabetic. High fives, you might even see 5.6 show up as normal. When somebody is in the, maybe above a 5.1 and they have these intermittent pains, that's something that's very, very interesting to me. There's another type of test that you can get, which is called the respiratory quotient. And it's usually part of if you're doing an RMR where this is a gas exchange. And the respiratory quotient is, you don't see it go down as low as 0, but it's on a scale of 0 to 1. And the higher the number, the suggestion is that you are using carbohydrates at rest to generate your glucose. And if you're at below 0.7, you're using fat, you're using fatty acids. That's what you want. That's what you want. I don't know the number. I think there's an accepted number in your respiratory quotient, which you'll find as RQ, is half carbs, half fat. You want it lower. You want the RQ lower, because if you're doing low grade activity for a super long period of time, aka rest, aka NEAT, non-exercise activity thermogenesis, you will likely be more advantageous using fat. Now, how does those two measures, which are similar, how does that relate to people that have this intermittent back pain? If there's lots of glucose, in more than ideal glucose in the bloodstream over the last 3 months, which is going to say it's a snapshot of any given time, then we know that if it's going to be very, very difficult to crack these fitness goals. And if those fitness goals are related to, even if there isn't a mechanical construct, that's a problem. So we're seeing with people that have these A1Cs in the middle fives and north, I'm certainly not commenting on if they have diabetes because they likely do not. But we're finding that that is a peripheral cardiovascular issue. Because if they're constantly using glucose, and I'll get to the RQ, but it's the same thing. If they're constantly, you have to use glucose, but if it's constantly in the bloodstream and you're not balanced in terms of what your insulin is doing and what you're doing to push out the glucose, you're constantly using these glycolytic systems. If you were using fat all the time, you wouldn't have that amount of glucose. You'd be burning fat all the time. There's other factors of burning fat all the time and ketones, etc. But it's not going to drive those glycolytic pathways that then lead to oxidants, reactive oxygen species, peroxidation of lipids. And those things is what wreak havoc. And that's the challenge that might be triggering this psychosocial component of pain. And it's going to make things very, very difficult to use carbs. Like you won't be able to train as hard because you're not going to be able to do well eating lots of the fast acting or even slow acting carbs, but because those are your primary energy sources to train really, really hard. So then you can't train really, really hard and you can't burn fat. So one option is to take a nutritional pathway, but I would also suggest that if we had more peripheral cardiovascular adaptations, aka mitochondria, and you trained for those things, then all of a sudden you would have an opportunity to use the more cheaper oxygen systems, electron transport chain, because you need the mitochondria to do it. If you don't have the mitochondria, you can't get into the electron transport chain. RQ is a clear example of what I am describing, where if you're not using fat, and we can argue if this is a valid, everything is a nudge, okay? So if you have some science that says RQ is not so great, I'm probably familiar with it. But I'm clustering all this information. I'm not going to linearly look at one thing and say X. But if there's a belief that you're using carbs at rest, which is going to be supported by your A1C, and then you're at 0.89 or whatever on your RQ, that means you're not using fat at rest. All the more reason to then train for peripheral mitochondria, and that is properly recovered intertraining within the training, high intensity training. That's where we talk about mitochondria in the myofibrils, mitochondria in the sarcoplasm. That's getting in shape in terms of 2020, hypertrophy of type 1 fibers, all of those training protocols, as well as others. Remember, nothing is in isolate. So if we even get after some central mechanisms, clearly doing long, slow duration will have a mitochondrial biogenesis. The whole idea is that, my opinion, is that their lack of ability to corral this back pain, it comes and goes. I cannot pin this on pathoanatomy. I can't pin this on a disc. I can't pin this on a trigger point. I can't, and plus, remember, we should have already been doing that on day one, the evaluation. So if they're fine, you can't even retest anything if they don't have pain. So hey, let's look at some of these other things. Like if it's not this, let's look at this. And I think a lot of times you should also be able to profile what somebody looks like and probably be not so surprised that their A1C is a 5.9 or their RQ is a 0.89, because that's telling you that they're not using fat to create energy. And you can't use fat to create energy without some of these peripheral, well, you can, you're not going to be great at using fat. I'm not going to let you do me like that. I'm going to catch myself. You're not going to be able to use fat without a preponderance of mitochondria. When you look at some of the messages of longevity and overall health, you look at mitochondria. Even if somebody comes in expecting physical therapy, fine. You don't know what I'm talking about. You think that's somehow out of your scope? Go ahead. Like, I'm pretty sure injury prevention and health maximization has everything to do with what a physical therapist is supposed to be doing as per the Practice Act of your state. Refer to somebody else. Good news, if you're a physical therapist, you're allowed to hire trainers. But we have to understand physiology, and we have to be able to look at metrics. We are not prescribing medicine. We are not diagnosing pathology. We are looking at real markers, no different than if you use your little goniometer, measure somebody's shoulder. It is a metric, and it is a fact. And what you do about it then is up for your decision. But I'm seeing that these factors, and it's all because if you're constantly using carbs, carbs are going through the glycolysis. Glycolysis isn't cheap, okay? It's quick, but it's expensive. It's fast pass at Disney. I know it's called lightning lane, and I won't do it, okay? You have to pay to get your lightning lanes, and you have to wake up early in the morning and pick all and stack all your things, but you have to pay for it, but you can get on the ride quicker. That's what glycolysis is doing for us. And you must use that when you're training intensely. But if that's the only option you have, you're paying, and the byproducts of those payments is going to make other forms of fitness really, really difficult. So that's a factor. Of course, there's going to be other types of markers on blood work that would probably also be a little bit out of range, either high or low, with those two. But those two are very analogous for this particular situation. A1C blood work, RQ through respiratory quotient, through some metabolic testing that typically you would also find your RMR, maybe you get your DEXA at the same time. So in the case of where someone, you do believe there is a metabolic construct to what their musculoskeletal pain is, and you're basically just gonna train them, where there's not a lot of special exercises, that absolutely can happen. And it's disgraceful if somebody does go to special exercises when they're not stimulative enough. Training people using precise or even just general physiological parameters can be a solution for certain types of musculoskeletal pain, usually ones that are intermittent and usually not supported by significant pathoanatomy. So what are we going to do? Let's say it's somebody way off. They're heavy, they're struggling. We have to figure out a cycle, a weekly cycle, microcycle, probably the best way. Just repeat the week, where they've got to lift heavy and they need to do stuff over a long period of time. So is there 1 or 2 days where we're doing some basic lifts that are safe for them? I don't know what they are. If somebody's really, really far off and obese, it's box squats, it's push-ups, and maybe we're not going to get into the parameters that are significant, but what can they do safely that's really, really heavy, so that we can start to build muscle, so that we start to use the carbs for the best procedures, the best policies. And then everything else is different forms of above or below threshold. If we're going to go above threshold for our cardiovascular or cyclic repeats, very, very short intervals and very, very long rests. Somebody who's significantly out of shape that's got this miserable A1C and or RQ, that might not be practical just yet. We're going to have to get less mitochondrial biogenesis and more central mechanisms, because I think we mentioned in the other video, it's never just one thing. So you're always getting lots of different things. But now, how do I get a little bit of everything? Pushing sleds, carrying things, farmer's walk, sled, walking backwards. Just literally walking backwards can be very, very useful. Marching in place. This is where unstable surfaces can have value. All I'm trying to do is make it harder for the person so they can have an increased metabolic demand for the same safe activity. So if somebody's got this very, very high resting heart rate and they're just, for lack of a better term, just out of shape, and that's why they have what appears to be musculoskeletal pain, we've got to pick 1 or 2 days of a high day and then a medium day of lifting heavy, and then all sorts of different forms of cardio where hopefully we're staying under threshold, where it's just nonstop circuits, but you're not burying them, where they're going to be able to maintain 30, 40, 60 minutes of continuous activity where the rest periods are as needed. And that is going to be a good factor. But the heavy lifting is also super, super important, so they get hungry. And we haven't even talked about protein in this process, because this process, the protein may not be directly related to those 2 metrics that got us to this discussion, but you kind of have to eat. There's always more to the table where we're talking about carbs and fat. Protein is going to be far, far crucial. And especially in the onset, heavy lifting and properly intense durations will make you really hungry, so that you're going to start to learn how to eat the right things. So cardio on your own, when you have some of these metabolic factors, everything starts from the left. You go for a walk. I don't think walking is cardio for most people, but for this person it might be. Walking in trails, walking in the woods, walking uphill, walking with a weight vest, walking with heavy hands, all of those things take a very, very low impact approach, and you get some free cardiovascular components to that. The big piece is that I just, I think circuit training is fine. Just use lighter weight. Don't think of it as using weights to build muscle or strength. You're using weights to make the movement harder, to make it more demanding over a longer period of time. So is it sets of 30, where you're clearly not focused on strength? But if you do 30 repetitions of dumbbell bench press, that's a form of cardio. It's certainly not the correct form of cardio. If you're training hard and you show me your little Apple Watch that has an average heart rate of 167, and you think that's asinine, and that's a whole nother topic. But if you show me average heart rate of 143, a huge favorite. It's got some drawbacks in terms of practicality, but kettlebells, Viper, where you're just moving with load. Now you need a whole bunch of these tools, and sometimes your whole philosophy has to be based on these things to justify having enough of kettlebells or Vipers or sandbags or weight vests or body bars, all of these things. You're just moving with load. And if you can keep the intensity low enough, you now have opportunities to train lots of variability. You're going to have a very positive work to rest ratio. You're going to go 3 to 1, not 1 to 3 that we would typically talk about for our peripheral stuff. So that's what the cardio is going to look like. It's training, it's lifting, but you're not really lifting weights to get strong. You're moving with resistance to make it more metabolically, cardiovascularly demanding. And if you do get stronger doing that, is because you were so freaking weak to begin with. You win again. When your bucket is so low, putting anything into it is going to make it better. And in other cases, even when you used to be strong, you probably didn't lose as much, and you were just so under recovered that primarily training subthreshold, largely using aerobic energy systems, put you into this environment of active recovery. And then all of a sudden, I'm not going to say you got stronger. I think you were able to express the strength that you already had.